So we're going to be talking about insomnia itself and some of the therapeutic options to manage insomnia. So insomnia is probably one of the more common sleep disorders that you would run into, and it can be classified in a variety of ways. So when it comes to insomnia, there's more chronic insomnia as well as short-term insomnia. And short-term insomnia happens in up to 50% of people. So they may have difficulty sleeping from time to time or occasional times where they're having challenges falling asleep or staying asleep. Chronic insomnia occurs about 10% of the time in adulthood, but increases in frequency as individuals get older. So older adults are a bit more likely to experience what we consider chronic or long-term insomnia, whereas young adults are more likely to complain about difficulty falling asleep. And our middle-aged and older individuals are much more likely to experience more of the middle of the night awakening experiences, like we talked about a number of slides back in previous videos. Women are more likely to experience insomnia versus men. So individuals who are assigned female at birth that have female hormones are more likely to experience that. And we actually see it more often in our older adults, like I mentioned, but also people with stress, both financial as well as social stresses. So things like unemployed individuals, people who are separated or widowed, those with lower socioeconomic status. And it is fairly common to have more than one illness that's kind of connected to insomnia. So 40% of individuals who have a diagnosis of insomnia also have an additional mental health condition. And sometimes they can really play into one another, where the insomnia can worsen the mental health condition, or the mental health condition can make the insomnia a little bit more difficult to manage. So anxiety, for example, can worsen someone's ability to fall asleep because they have sleep anxiety. Whereas difficulty sleeping can cause changes in stress hormone and be negative towards affect, etc., and can have that interplay with other mental health conditions. Now, when someone's coming in with complaints of insomnia, we want to consider what other things may be contributing to their experience. So insomnia can sometimes be just situational. It still stinks. It's still difficult, but it could be due to stress. It can be due to life events or conflicts. We can also see changes in people's circadian rhythm from things like jet lag and shift work. So if you've ever flown a plane far enough that the hours of the day are significantly different, you might have challenges in falling asleep. Additionally, people who work night shifts or alternating shifts, swinging their shifts, have a bit more challenge in falling asleep consistently because that circadian rhythm, their day-night cycle, can be disrupted. There's a number of medical conditions associated with difficulty sleeping. So from a cardiovascular or heart perspective, we can see things like angina, which is chest pain, arrhythmia, so your heart rhythm is off, if you will, heart failure. And there's some physical challenges with heart failure where laying flat on one's back actually can be uncomfortable or make it harder to breathe because of swelling or edema in the body. And they may actually have to sleep on pillows to sleep more upright, and that can be uncomfortable. Respiratory illnesses like asthma, sleep apnea, and COPD, chronic obstructive pulmonary disease. We see endocrine challenges like diabetes and hyperthyroidism are associated with some challenges with sleeping. Gastrointestinal, particularly gastroesophageal reflux disease, so GERD, especially if you have, say, like a hiatal hernia, which is when there's sphincters right in different parts of your body that close off stuff from moving out or into the space. And a hiatal hernia can be parts of the gastrointestinal tract kind of sticking out wrong, if you will. And that can cause stomach acid to not be well closed off. If people have significant stomach acid problems, laying flat, similar to heart failure, may be more difficult, and they'll experience discomfort from that. Stomach ulcers can be similar in that sense too. Neurologic conditions such as delirium, epilepsy. We see a lot of insomnia with epilepsy as well as Parkinson's disease. And then pregnancy can cause a lot of challenges with comfort during sleep, hormonal disturbances, increased rates of things like GERD can happen as well. So we do see some challenges with sleep when individuals are pregnant. Psychiatric conditions, mood disorders, particularly bipolar, if someone has hypomania or mania, anxiety, again, that's sleep anxiety. Substance use disorders can disrupt the quality of sleep, but can also disrupt the ability to sleep. So if someone's taking stimulants, that can be difficult. If someone's even taking depressants like alcohol might make someone feel sleepy, but actually significantly decrease the quality of the sleep that the individual is receiving. Going on from that, medications, right? So medications such as anticonvulsants, because they affect the brain activity, certain central adrenergic blockers, so certain blood pressure type pills, diuretics or water pills, because they make you pee more. And when you pee more, you get up more at night to pee. So that's why if someone's on like a Lasix or a hydrochlorothiazide, HCTZ, usually we recommend taking it in the morning because you're going to be peeing more during the day and it won't be as disruptive to sleep at night. Selective serotonin reuptake inhibitors, certain antidepressants, can make people feel more awake. For some people, it doesn't do either of the, make them feel awake or sleepy. And for some people, they feel sleepy. Serotonin's a little funky in that sense. Steroids, because it's literally stress hormone. And stimulants, of course. So stimulants stimulate your brain. So whether it's a stimulant for attention deficit hyperactivity disorder, narcolepsy, idiopathic hypersomnia, sleepiness from obstructive sleep apnea, they can, especially if taken later in the day, can produce insomnia, difficulty falling asleep. From a diagnostic perspective, this is what we got. So there's really two places that offer sleep-related diagnoses primarily. So we have our DSM, our Diagnostic and Statistical Manual, but we also have the ICSD, so the International Classification of Sleep Disorders as well. So these are the various types of sleep disorders. We have insomnia, narcolepsy, circadian rhythm, parasomnias, which we won't talk too much about. There's really no medication treatment for parasomnia. So that's things like nightmare disorders, sleepwalking, etc. Substance or medication-induced sleep disorders. And then on the ICSD side, we have just kind of slight deviations in how they kind of describe some of these, but they're still inherently the same types of conditions, right? So we have, they also have jet lag in there. They break out narcolepsy to the types of narcolepsy. So because we have narcolepsy with and without cataplexy. Cataplexy is that sudden loss of muscle tone, typically following an emotional experience or excitement, something like that. So not everyone with narcolepsy has those types of drop attacks. That's what you see in like movies and stuff. That's not everyone has that. You can still have narcolepsy and not have that. And then, they break down the insomnia into short-term and chronic insomnia. So when we're talking about insomnia is defined as dissatisfaction with sleep in the sense of the quality and or quantity of sleep. So either they're not sleeping enough or they're sleeping very poorly. And this can be a variety of different experiences. So people can have difficulty initiating sleep or falling asleep. People can have challenges with maintaining sleep, so they might have middle of the night awakenings. And they may have early morning awakening and inability to return to sleep. So some, especially with our older adults, we'll see they'll wake up at like 4 o'clock in the morning and be unable to fall back asleep despite not getting a full night's rest. In order for it to be diagnosable, it has to cause significant distress. Again, there's these unicorns that can sleep like 5 hours a night and they're totally fine. And the cutoff really is 3 nights a week for 3 months or more. So that's really going to make it chronic, right? If it's happening consistently for a long time, then we are going to see that it's chronic in nature, right? So the three times for 3 months or more. Okay. And this occurs despite their opportunity to obtain appropriate sleep. So what does that mean? If you're up studying, if you have a newborn, etc., and you're just not having the availability of sleep, that's going to be considered a little bit different than insomnia, despite having ample opportunity to sleep. And of course, we're going to explore some of those previously discussed contributors to insomnia to ensure that those are addressed appropriately if able to. So we classify, we have our transient or short-term Insomnia, so transient's less than 1 week, so really occasional. Short term is within that 1 week to 3 month. Chronic is 3 months or more. Primary versus secondary. So primary would be it's insomnia. Like there's not really underlying stuff. And then secondary is oftentimes considered symptoms associated with some other condition going on. So primaries are kind of light sleepers, right? People who are easily aroused by noise, by temperature. They have a difficult time calming down essentially and falling asleep. We always want to make sure that we're ruling out those other things like sleep apnea, restless leg, limb movement, etc. when we're taking into consideration if it's primary or secondary. And in order to do that, we're going to be looking at some of the sleep parameters, our goals for sleep, how people are sleeping, right? So, and we talked a little bit about this a couple of videos ago when I talked about my sleep study. So we want to look at their sleep onset latency. So how long does it take from them trying to go to sleep to them actually falling asleep? And that should be less than 30 minutes. So a goal for insomnia for really anyone is you should be falling asleep 30 minutes or less after you lay down. Should have a total sleep time, which is your time in bed minus the time you've spent not asleep, of 6 hours or more. So we want you to get that full night's sleep. Wake time after sleep onset, which is the time essentially that you spend awake, not how long it takes before you wake up, but how long you spend awake between bed and up for the day, right? So what is your wake time after sleep onset? And then your efficiency, so your ratio of total sleep time versus time spent in bed. So you really want that to be more than 80%. So you don't want to be wasting time in bed, I guess you could say, right? So we want to have really good values here. These are our primary goals for treatment of insomnia. Now, there are a number of different ways that we can treat insomnia, and I'm actually going to save this for the next video. So we've got some what we call pharmacologic, which is medications, as well as non-pharmacologic interventions that can be used to help people who are experiencing insomnia. I'll see you maybe in the next video. We'll talk about meds and stuff. It'll be great.